This is a picture of the hotel that the exam will be in the next 2 dates at least, in February and April. So I will give a quick, just like 2 slides about the venue and the PPE preparation and stuff, 1 or 2 slides about the Viva, and the rest will be about, the main concentration will be about the clinicals. My colleague Joe Gowda will also present about the short cases. So as I said, it's the Crown Plaza in Glasgow. The clinical and the Viva, they will be in the same venue. One of the changes that they divided the candidates into two main groups, and that will allow everybody to stay for 1.5 day, maximum 2 days in Glasgow, and then they will ask you to travel straight away. So the red and the blue groups, the red group will stay Sunday, do the Viva whole day, finish the Viva, and the Monday morning they will finish the clinical and they will leave by lunchtime. The other group will start Monday afternoon doing the clinicals, and then the Tuesday will be whole day. When you come, there will be temperature check, and then they will do your registration. If your temperature is high, obviously they will ask you to leave, and it's a one-way system. Everybody should wear a mask all the time. They have got plenty of masks everywhere, so you don't need to bring your own mask. I find it a bit difficult to talk while you're stressed in a noisy like hall where everybody's talking, especially if English is not your first language and you have an accent. It might be difficult for the examiner because they might normally they rely on reading your lips and they can't do that. So I would suggest for candidates preparing for the exam to try and practice their Vivas while they're wearing masks. That might help. So it will be a big conference hall. The tables are arranged with social distancing, but there will be no screen or any visors or anything. You will sit with 2 examiners. It's the same venue for both the clinical and the Viva, where you will be. It's quite relieving because you will be used to it. It's not a new place. You will do the Viva, for example, the first day, and then the second day will come for the clinical, exactly the same place. This is a picture actually of the actual place where you should be going. In this hall, you will be waiting, and then the hall for the exam will be just to the right. This is a hall where you will be sitting in different range tables. And in the Viva, there's not many changes happen in the Viva. I've noticed because I have taken this exam before, the difference is mainly that you would definitely need to know at least 4 differential diagnoses for everything. And that is, I would say that is the most important point. If there is one thing I would ask the examiner to take home message, it would be this one, because I will explain this later, but if you don't know the differential for everything, then you would struggle to score marks, because there will be questions on these differentials on each of them, and they will show you X-ray of each of them. So you might be shown an X-ray for all of the possible differentials and asked to how you would approach everyone. If you miss one of the main differentials, you miss a lot of marks, and these marks of that differential will be automatically lost. I'll just give you an example to explain this, because this is a very important point. It is in the Viva, but also I noticed this in the clinicals. So see that patient, you would say, I can see there is a left side wasting on the supra and infraspinatus, and I can see prominence of the spinal scapula. That's a level 6 question answer. But if you are preparing well for this exam, you would avoid being asked about all the differentials by commenting your first comment and avoiding prompting. You would mention all the differentials from there. So you would say, I will be looking at the deltoid, if it's wasting or not. The deltoid is not wasted. I'm thinking this is not brachial plexus or persona alterna. I'm suspecting this most likely rotator cuff arthropathy. Looking at the winging also, and that will also give you an impression whether it's a brachial plexus injury or a rotator cuff arthropathy. And also commenting on the other side is unilateral or bilateral will give the impression that you're talking about the facioscapulohumeral dystrophy, which is also one of the differentials. And say I would like to look at the face, look for Horner syndrome, and look for transverse smile, and asks the patient to whistle. By saying that from the beginning, you would stop the examiner asking you about the differentials, which are, now you mentioned all the differentials, and the examiner cannot fail you. So these are like very similar to one of the questions I had, and the case was maybe talking about one of them, but I noticed the examiner have shown me X-ray or a picture for all of the 3 or 4 differentials. So they might not ask you about all these things. The white thing is the history findings and how would you differentiate between these. The blue is how would you differentiate in examination, the investigation findings in yellow, and the treatment in black. Okay, so persona alterna, young patient, it's painful, there's no trauma. You differentiate that in a history from rotator cuff, where the patient is older, it's unilateral, there is shoulder pain, most likely this patient had a fall or dislocation before, or maybe there is no trauma. Facioscapulohumeral dystrophy is there's a family history, it's painless. And you go like that. They might not ask you everything, but they will make sure that you can differentiate between the important differential for every single case. And then they will come back and concentrate on the main diagnosis. That's most likely the diagnosis of the case. And they will ask you a bit more question about the causes, like if it's persona alterna, they'll ask you, what do you think the causes is? Then you talk about brachial neuritis, whether it's viral or other causes. So for the intermediates, you're expected to demonstrate clinical tests without prompting. And that was said to us in the briefing when they said you try to demonstrate the clinical test in yourself, and because you will not be allowed to touch the examiners or and there is no patients. So you need to think of reaching the diagnosis before you get into the X-ray. You can have also, because this is all virtual now, you can have a lot of rare cases that normally they wouldn't come to the exam. You can have also pediatric cases. As I said, at some point, I felt that I had to stand up and take a few steps away from the examiners because they asked me to demonstrate how I would do the movement of the shoulder and test the rotator cuff in myself. And I looked around, I found most of the candidates standing up, and as if we're doing group yoga. Taking history, there is some changes here, really important to focus on. There's 2 ways of taking history in the intermediate. One will be a traditional, conventional way where one of the examiner will be the patient. So we give him a name, and you will approach him as a patient. He will answer the patient, and he will give you a very nice history. 5 minutes more than enough to take you. The difficult scenario is when the asking examiner is the same one who gives you the history. And this happened to me and happened to Joe as well in one of the intermediates, where the examiner will say, well, you have a patient of this, what do you want to ask in history? And then everything you said, he will say, why are you asking about this? What? And they will just grill you every question. I notice in that station, the other examiner will just be writing and sitting there. He will not open his mouth till the end of the intermediate case. So you will be taken by one examiner through the whole 15 minutes. So it's very important in that situation to not rush, because this is the same person, he will give you the positive findings. So if you say in the history, I would like to ask about handedness, about occupation, and about the presenting complaint in the same sentence, then he might not give you all that. So you have to ask and wait for him to answer your question. If you don't ask about anything, he will just ignore it, and you will count it as you don't ask, you didn't tick the box for that one. As I said, you need to justify why you're asking every question. So you need to be really careful of not asking a question that is not relevant. They will look at you as not as a MRCS candidate rather than FRCS. And for example, don't ask about family history in a patient who is post-traumatic known osteoarthritis of the knee, for example. They will not like this. Always remember the safety questions, and this will be very important. And I noticed the examiner will, if you don't, they will prompt you to ask about it, especially in spinal cases. You need to really make sure that you're asking about these. So just remember, these scenarios are made very carefully. We noticed that all the examiners and in the briefing, they were very worried about how we're gonna respond to this and about the feedback. And they told us they have tested this several times between themselves. So every scenario is carefully put, and any positives they give you in the history, that is not for fun. That will be a question, a positive finding. They will expect you to respond to it and to show your higher order thinking. So for example, if they say in the past medical history they have asthma, you have to say either in the same time to the patient, or if you have good short-term memory, keep it to the discussion, but you have to mention about you suspecting about steroids because this patient takes steroids, you asking about hip pains because they might have AVN, you talking to the anesthetist because these patients might need some steroids with anesthesia. Also, another case like protein CNS deficiency, you have to ask about medications because these patients take warfarin, and you have to mention that you would stop this before the surgery. And there is that. So this is about the history. On clinical examination, there's a very important point you have to put in your mind, that you have to remember you are not scored for knowledge here, you are scored for skills. So it's shown a clinical picture. You will be shown by the end of the history, the examiner will turn his laptop or his tablet and he will show you a clinical picture, and you need to describe it as you would examine this patient. So by looking, and then I would feel for this and I would move this. Remember, intermediate case, because it's just talking on the examination, you can go very quick. In 1 or 2 minutes, you can say all the sequence of the of what you're going to examine for, but they will stop you to make sure that you know what you're talking about, and they will not make it easy for you. So I would think that in intermediate case, you still need to go systematic by, for example, in the hip, you have to look from the front, from the back, from the side. You have to walk the patient, do Trendelenburg, sit the patient, lie the patient down, and do the leg lengths and these things. But you mention it very quickly to get to the meat, because if you don't go very quickly, also you will lose some marks. They will get you to that point, and then the examiner will give you the findings of what you're asking for. So if you've got a leg length discrepancy, for example, which can come very frequently in the intermediates, they want you to get to the Gileadi test. They will not show you a simple Gileadi test where there is a like shortened tibia and that's it, and the rest is normal. They will show you something complicated, and they will test your high order thinking. And unfortunately, this will be your competence question. If you don't pass that question or go beyond that, you will not pass the examination, or you might not fail the whole intermediate. So one of the scenarios you could have, for example, one leg shorter. The patient had, when you do the Gileadi test, they will test that you know that you're going to put the heels together, and then how you're going to check the tibia, how you're going to check the femur, and then your comment will be, for example, the shortening is below the knee, and then, oh, I notice also the femur on the same side is longer, and then they'll ask you why. And then, oh, I can see some scars. This patient had lengthening on the same side where he had the shortening. And then they will ask you that, then it will turn into Viva. So you need to really understand the concept of every clinical test that should be learned in depth. And you need to know the false negatives and false positives of every test. Like if the patient has fusion of the hip, Trendelenburg test would be negative, although the abductors might be weak. So how to prepare for this clinical, I would suggest for all the candidates taking the exam soon is to go to this book, Nick Harris and Fazal Ali book, and trying to find all the important clinical tests and ask themselves questions about that test and know everything around it. For example, if you ask to assess the collaterals, they will ask you why you need to flex the knee to 30 degrees, the elbow to 30 degrees, and you know that's disengage the olecranon of the coronoid fossa to be able to assess the collaterals. For Trendelenburg, they will ask you about hip fusion. If it is fused hip or fused knee, how would you perform the test? As I said, Gliazzi will not be straightforward. Coleman block tests, they will ask you about the possibility if it does not correct. So it should be either hindfoot driven or, for example, stiff. But you would confirm by doing the movement of subtalar joint. Thomas test as well. They would not give it straight, they will give you with fused hip or knee. Elson test, for example, also. You need to check that the DIP joint is double first before you do the test. You need to check for scars, that there is no fusion or there is no screw gone just under the nail plate. And that's as well as for dial test. You need to ask yourself why you're doing the posterolateral corner in 30 degrees, why you're doing the PCL in 90 degrees, can the PCL be injured while the posterolateral corner is intact? A lot of questions that will come up in the next exams about these things. So I cannot emphasize enough the importance of revising these things. The discussion will be like a normal, but I don't think the discussion will be anything different from what we know already. But do not be alarmed by there's no x-rays, because actually these things, we realize it takes a lot of time, and the examiners knew that, and they did not, most of the cases, even in the intermediates, there is no x-rays. So that's normal. If you don't see an x-ray, that's very normal. You should come up with a clear management plan that should be targeted to the patient you have seen and not just a generic management plan. You need to be slick to read the consent, because in every intermediate case, there is some marks put for the consent. And I have been asked about it in both intermediates. So do not miss these marks. Be very slick, and trying to do drawing is a very good idea of consenting, and most of the examiners will like it. I think that's the end of my part, and my colleague Joe will finish the short cases. Thank you very much.
Thank you, Mohammed. So for the short cases, briefly, just in 5 minutes, I would like to just highlight the differences between the normal and this time. So this time, it's the same, 3 upper, 3 lower, but there is more and more spine cases. There is more and more pediatric cases, and more cases that we didn't really have on a regular basis on every in every exam before. So the scope has increased. It almost always starts with a clinical photograph, okay, of the main deformity. It's almost always there is a finding in this clinical photograph. It's not just a subtle finding, it's a major finding. Saying that, if you can't see it, just ask the examiner. But usually it's very obvious. And if it is it's usually one main diagnosis with that deformity. It's not a differential. If there is any important differential, okay, say, but usually it's one diagnosis for one deformity. Next, please, Mohammed. Be slick in describing, because you're not marked for just describing the what you see. Okay, this is actually, it's just the look. You look to this. Okay, so this is a clinical photograph of scoliosis, and then you start mentioning the shoulder, the waistlines, the pelvic obliquity. You have to, this is the main point, you have to say any positive and any negative points, any associated conditions. So whether or not you can see, in this case, whether or not you can see tuft of hair, whether or not you can see café au lait patches, whether or not you can see any associated or causative diseases. Then, if you know if there is any differentials, briefly mention them, and then go to the meat straight away by not wasting time about, well, I will look to the patient from the front, from the side, from the back. I will look from the front for shoulder level and from the back for shoulder. No, just go for the meat of the exam or the test that you will do to either affect your diagnosis or affect your management plan. Next, please, Mohammed. And then describe that main test. They will ask you about, for example, here, I will do Adam forward test. So I will do Adam forward test to see rib hump or rib prominence, and how would you do it? I will stand behind the patient. I will ask the patient to do this and this and this. Okay, that's how the short cases were done. For the first minute you describe, for the second minute you're describing the very important tests that will affect your management plan. Then if there is anything that they are that you asked about in the short case, like if you ask about café au lait patches, and they can show you either another picture of café au lait patches for that, or they can actually zoom in to show you, oh, there is café au lait patches, which happened with me. Okay, then the brief thing about the management. So, for example, just a quick example, this case, okay, this is a clinical photograph of a child suffering from Cubitus Varus. Then he will ask you, what is your differential here? So you can mention that the two most common differentials is either a malunited supracondylar fracture humerus versus a lateral condylar fracture. The next question would be, okay, so how would you differentiate that? If you go for the X-ray and to calculate the Bowman angle, which like that, no, they will tell you, sorry, there is no X-ray, we don't have the X-ray, and you are not supposed to ask for the X-ray before clinical examination. They want to differentiate according to the clinical differentiation. So they will ask you what test you will do. You will say the equilateral triangle. Next, please. So the equilateral triangle, briefly, is that if the edges of the triangle are equal, so that means the deformity is coming from outside the triangle. That means it is a supracondylar fracture. If they are not equal, that means the affection of from inside the triangle. That means it is a lateral condylar fracture. Simple as that. You have to know the concept of the test, how to perform the test, and why you are doing the test. Next one, please, Muhammad. Hello?
Yeah.
Hello? Can you hear me? Okay.
I hear you.
Yeah. So for the discussion, it's the last minute or two. It's a normal Viva, but don't expect X-ray, MRI scan, or anything like that. It's basically a normal Viva. Saying that, they expect you to know what will you find in the X-ray. For example, in this scoliosis, if it's cafe au lait neurofibromatosis, what are the significant findings in that X-ray you are looking for? So that's the main Viva here. The Viva starts here, and then the management. Brief management, and then the higher order thinking. Okay, next one, please. So take home message about the short cases briefly. Don't panic. If not clear, just ask what can I see here, or I want to see whether or not there is that sign. Don't waste time describing the clinical photograph. You're not scored high about just waffling around. Okay, this is a male, this is a female, blah, 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 if it's not significant. Prepare differentials if they are important, and then describe the tests. Okay, description of the tests and why you are doing the special test, not all the tests, not the classical format of look, feel, move. You don't have a patient. You have an examiner in front of you. He's frowning to you all the 5 minutes, okay? And if you waste your time about, I will look at the patient around and around, okay, he will be very annoyed. Thank you very much and good luck. Questions? I know there's hundreds of questions here.
Very brilliant. Thank you very much, Muhammad and Joe, for your insights on this exam, and congratulations again for passing. Seem to be a lot of changes, lots of pros and cons for the new format, but whatever it is, we just got to get on with it. And so, as you said, probably, there are no patients, so maybe a little bit better interaction with the examiner, but then now they have the freedom of bringing any case they wish. They're not restricted by availability of patients anymore. So we've got to accommodate for that in our preparation. So thank you very much, Muhammad and Joe, again. I think we will end this teaching session with this. I'd like to thank Ruth and Hannah from OR UK for sticking with us and for organizing this beautifully, this session. A lot of hard work behind the scenes to get this up and running. Thanks to my colleagues at the FRCS Mentor Group and to those who took part in the Viva, the examiners, Nikki, David, and Abdullah, and the candidates as well for coming forwards. We will have teaching session every Wednesday, and the course is obviously upcoming. So thank you very much, everyone. And I think everyone must be tired now. Thanks for attending, and good night, everyone. Bye-bye.
Good night.
Good night.
All candidates can please kindly log out. Thank you.